Thank you for joining us today, Jane. And from hearing you speak about telehealth, it seems that CommonSpirit is really trying to figure out how to do this successfully. Your experience really echoes what we found in a recent AMGA Telehealth survey, that in the year 2020, telehealth in the first half really skyrocketed, and then over a period of time it declined. And now AMGA members are trying to figure out how to integrate telehealth into their care delivery models. And that's what we're here to discuss today, how really CommonSpirit is thinking about the role of telehealth in serving your community and your patients.
Sure.
Excellent. So my first question today is, what were some of the early myths that we believed about telehealth that maybe haven't borne out and haven't been proven to be true?
Wow, there's a lot of those, right? So I think probably, the biggest ones when it was about a numbers race at first. I think everyone thought, you were hearing all of, it's going to be 50% of the visits going forward are going to be virtual, which obviously we had to get our arms around that one pretty quickly and debunk that. I think another one really is that virtual care is more efficient. I mean, the reality is, where we started in the pandemic, and it was not, and it still isn't, because of the infrastructure. There's so many areas that didn't have the bandwidth, the equipment, patients didn't have access, and so the efficiency piece really is, would indicate that we have the right queuing with physician templates and all sorts of things. So that one really absolutely didn't play out, and was mostly being said by people who weren't in practices. I think another one, and that's probably one of the most dangerous ones, is that it's less expensive. I mean, frankly, that nothing could be further from the truth. I mean, we did do the numbers because we were hearing it so much. And in our system, when we were at our peak of virtual visits, we were really seeing those being about 7% less expensive overall. And, but at the same time, you're hearing screaming across the room, it'll be 50%, 50% of the costs are going to go away. Well, the reality is our biggest and most important investment is in our providers, right? They're right there front and center. So that's not changing. If anything, we need them honed in on, we need that skill set to diagnose and treat on video is a skill set all its own. And then, our structures, our leases, our buildings, those don't change and quickly, and nor does staffing. So that was one of the myths early on that did a lot of damage that we had to get around because we also all had to make a bigger investment in the equipment and the systems that we have. So I think that one, and then probably one more that did not serve us well early on, is that, I think nationally and politically, this belief that telehealth was going to lead, excessive use of telehealth would lead to fraud and abuse. And again, as we know, these were replacement visits, or, this big surge of visits early on, it wasn't a net new book of business. And our numbers certainly proved that out, that we were really, in the full scale pandemic, really just replacing visits with virtual. So I think those are probably the biggest ones. And probably plenty more that we had in different places. But I think also maybe that patients love it and they're never going to go back. We've seen that not to be true. They were appreciative of it, right? When it was the only way they could be seen, but we saw those numbers change everywhere once in-person care was available again. And that the real patient satisfier is probably a combination. So.
I've heard you talk about telehealth 2.0. Tell me, what is telehealth 2.0 and what's it going to take for us to get there?
Yeah, sure. I think, well, first of all, I think we have to really, really be serious about the fact that what we are doing in virtual health has to be clinically driven. All those other voices and a lot of those other myths, with due respect, everyone wanted to be a part of this and a piece of it. So all of our other business stakeholders and partners voices really sort of need to, calm down a bit behind that and let the providers, let our clinicians direct what's appropriate. I think that's the backbone of it, and making sure that we honor that. I think the other piece is we've got to close gaps in training and tools and solutions and technology. I mean, if it takes a provider longer to log on and then do a visit than it would have to see an in-person visit, it's never going to transition. And then, also it's the quality of that visit. Again, do we have connectivity? Do we have the bandwidth? Do patients have access to it? So all of those things have to be in place. And I think then we also have to sort of build bridges across the care continuum. So it's not just this replacement visit, but where else can it be used? How do we use this? We have to change that gradient, that level of difficulty for providers going forward, and understand that it's a piece of our access portfolio. It's not this, new thing. It was sitting here already. We didn't have the enablers to push it forward. And so I think just really acknowledging how it should be used. And as always, making sure that it's clinically driven.
Yeah, I've heard you talk about CommonSpirit, that you're building a clinically driven framework. What is that? And tell us why it's so important.
Sure. Well, I think, again, getting the technology right and all of those pieces is important. But, for the long haul, if we ever get past this pandemic, which hopefully is coming, we're never going to go back to, we're not putting that genie back in the bottle. Now people are using it and they become more comfortable. But how and where? So for us, we took, some moments in time, from early on. I mean, of course, there was the immediate surge, but in the first lowest points, when it started to die back, we spent time building up a group of clinical leaders who started to look at what's appropriate. So, and how do we use it? So they started they literally built a tool and ran over 8 million visits through this scenario to say, what is appropriate? Of all the visit types we do, what is going to be appropriate and what are those categories? From that, they built some guidelines. Again, this is about ease of use for providers. And if we're ever going to have like a solution that allows people to schedule into virtual, what could it be? How do we make that easier? And then from that, they built sort of an evidence-based template library. So providers, again, had the right templates queued up, had access to all of those training solutions. And then, sort of looking across that sort of an automated feedback loop for the people who are doing this work to actually weigh in, right? This is a new way I've found to use them. This is what did work, didn't work. I think making that, that tool that they put together early on, that dashboard for how and when to use visits continues to get better because we have more and more provider input and experience with it. And I think that's what, for us, has been ahead of the curve in driving. Well, every consultant everywhere is going to tell you what's the new frontier look like, what service lines. We wanted that to be directed by our clinicians. It may not be varied very much from the very smart folks out there doing the math and the science behind it. But for us, it's really about, let's make the ease of use there. And then let's look in with each specialty. There's probably a place for it everywhere, but it has to be the right place and the right time. And that for us is what is really, that's sort of the clinically driven. We like to say that we're clinically led, we're operationally enhanced, and then we're digitally accelerated. If the first two pieces are right, the digital solutions will accelerate.
So speaking of what needs to get right, policy needs to get right around telehealth as well. What things does AMGA and AMGA members need to do and to be looking for in the policy front?
Well, I think, advocacy is just talk about it, talk about what really happened in your, with your experience in your markets. I think our story is very similar, this rise and this, fall, and how do we have a place for it going forward, and what do we need? I mean, the reality is, there was a letter drafted for Congress that many organizations across the country signed on to, and in that is an ask that the current telehealth waivers be extended. This looming fear that they're going to go away, it really inhibits, how we're making decisions around budgeting dollars. And we don't have our infrastructures built to do this well yet. So we've got to have some certainty about what that looks like going forward. So telling that story, telling that story of how you're using them within your system, and that whole clinical side of it, really debunking that piece that this is just really another piece of our access work. It's, it's not this net new business that's being created as a result of it. And then I think the other part is asking that, all of the studies that are being done and looked at, where we're looking, where politically it's being looked at across, have all of that work completed while we still have an extension, and then build that into a dashboard, like the letter was asking Congress to do that, so that it's a fair assessment, that we have as much data, rich data as possible before those permanent decisions are made. And then, if we've asked for an extension to 2024, be ready to put permanent legislation in place at that point so that we can continue to expand this work. I mean, we know it's going to improve access. It's going to sort of level the playing field in areas that are so difficult to reach, specialties that we can't take to some markets, but we simply can't do it if we can't afford to do it. And I think that's, the stronger the voices and the more voices we have saying that in unison, the better.
Well, excellent. Thank you for your time.
Sure.
And AMGA, through our policy department, is pushing hard for those telehealth waivers, exactly as you described, to make them permanent, but to do the studies to understand. And as you mentioned, AMGA members are a key part of that, to let their voices be heard about the value and how they're using telehealth to improve care for their patients. Thank you for your time today, and wonderful talking with you.
Thank you for all that work that AMGA is doing always. I appreciate it. And appreciate the opportunity to talk with you.